My name is Dr. Ben Holloway. For 15 years, I ran the floor of a Level 1 trauma center in Pennsylvania. My world was a landscape of controlled chaos, governed by science, protocol, and the unassailable truth of data. In the ER, you learn very quickly that a patient's story can be misleading, clouded by pain or panic. But the numbers, the images, the lab results, they are the bedrock. They don't feel, they don't guess. They simply are. That belief was the foundation of my entire career. It's what allowed me to make life or death decisions in seconds. But what happens when that foundation cracks? What do you do when the data tells you a man is perfectly healthy while your own eyes are watching his flesh being devoured by a substance you can't identify? In October of 2009, a farmer walked into my ER and brought with him a question that had no answer in my textbooks. He didn't just challenge a diagnosis, he challenged the very nature of evidence itself. To the uninitiated, the emergency room is a maelstrom, a perfect definition of chaos. It's a polyphonic shriek of a dozen different monitors, each one screaming a story about a heart rate, a blood pressure, and oxygen saturation. It's the frantic squeak of gurney wheels on linoleum, the sharp, clipped voices calling out orders, the constant layered assault on the senses, the iron tang of blood, the acrid smell of vomit, all of it underneath the sharp, clean scent of iodine and antiseptic that never quite manages to cover the human reality of it all. But for me, this wasn't chaos. It was my orchestra, and I was the conductor. For 15 years, my job was to stand in the heart of that hurricane and impose order. I thrived on it. I remember one night, a multi-car pileup on the interstate had sent us a flood of trauma. A young man was brought in, unconscious, with a dozen competing catastrophic injuries. The paramedics were rattling off his vitals. A nurse was shouting about his dropping blood pressure. His leg was obviously broken. He had a headlock. It was a symphony of disaster. And in that moment, my training took over. I silenced the noise. The patient's story was written in the language of his wounds, but the real truth was hidden deeper. I didn't guess. I didn't theorize. I followed the protocol. We pushed him straight to the trauma bay, and I began the litany. Get me a full blood panel, toxicology screen, cross-match 4 units of O-neg, and get him to the CT scanner for a full-body scan, now. The team moved, a well-oiled machine following my commands. 20 minutes later, I had the truth. The CT scan showed a ruptured spleen, an injury that was completely invisible from the outside but was rapidly bleeding him out internally. The data told me the story his unconscious body couldn't. We went into surgery and we saved his life. That was my world. That was my faith. I believed that every medical problem, no matter how complex or terrifying, was ultimately a data problem. The human body was a machine, and I was the mechanic. My job was to use my tools to find the broken part, and the tools never lied. A patient's story? That was subjective. I'd had people swear they hadn't taken any drugs an hour before their toxicology screen came back positive for a pharmacy of narcotics. I'd had patients describe a pain on their left side when the tumor was on their right. The stories were just noise. The data was the signal. I had built my entire identity around that certainty. I was the man who could walk into any storm and, with science as my compass, find the way out. There was nothing that couldn't be categorized, nothing that couldn't be identified. My confidence wasn't arrogance. It was a deep, abiding faith in the system, in the science I had dedicated my life to, a faith that was about to be tested beyond its breaking point. My faith wasn't in myself, not entirely. It was in the protocol. Over the years, I came to see the diagnostic protocol as the single most important development in modern medicine. It's a bulwark against the two things that can kill a patient faster than any disease: panic and guesswork. Before the protocol, medicine was a dark art, full of superstition and anecdotal remedies. A doctor would rely on instinct, on a hunch. But the protocol changed everything. It transformed medicine into a science. It gave us a map, a flowchart for navigating the chaotic landscape of human suffering. And the heart of that protocol, the very first commandment, was to separate the signal from the noise. The noise was the patient's story. I know that sounds callous, but years in the ER teach you a hard lesson. A patient's perception of their own body is one of the most unreliable narrators on earth. Fear changes things. Pain changes things. I've had men clutching their chest, swearing they were having a heart attack, only for the EKG and blood work to show it was a severe panic attack. I've also had patients come in complaining of mild indigestion who were, in fact, in the middle of a massive cardiac event. Their stories were wrong. The data was right. The data was the signal. My job was to be a translator. Patients speak the messy, emotional language of perception. The machines, they speak the pure, objective language of physiology. The clean, rhythmic peaks and valleys of a heart monitor. The stark, beautiful clarity of a CT scan. The absolute, impartial numbers of a blood panel. That was the truth. My entire methodology was built on this foundation. Ignore the story until you have the data. The protocol was king because it was impersonal. It was a system forged in the crucible of millions of cases, of countless trials and errors. It was our shield against the darkness of the unknown, and I held onto that shield like a priest holding a cross. It had never failed to protect me, to illuminate the path forward. No matter what walked through the doors of my ER, I believed, with absolute conviction, that the protocol would provide the answer. It was a Tuesday in October, and the rain was coming down in cold, relentless sheets, which always meant a busy shift. The ER was humming with its usual litany of broken bones from slippery sidewalks and the first coughs of the seasonal flu. It was all routine, all part of the predictable rhythm of the season. And then the paramedics wheeled him in. His name was Jacob Miller. He was a farmer, and you could tell just by looking at him. He had the thick, calloused hands and the weathered face of a man who spent his life outdoors. But he was pale under his tan. His eyes were wide with a feverish, bewildered panic, and he was shivering uncontrollably despite the heavy wool blanket they had wrapped him in. The initial report from the paramedics was bizarre. High-grade fever, acute disorientation, and a severe, unidentified localized reaction on his left hand. As we transferred him to a bed in the trauma bay, I got my first look at it. His hand was swollen to nearly twice its normal size, the skin a taut, angry red. And it was coated in a thick, quivering, almost clear jelly. It wasn't a chemical I recognized. It didn't look like any biological agent I'd ever seen. I started the protocol. Let's get a line in him, start him on a fluid bolus, and get a full set of vitals. As the nurses went to work, I leaned in close to the patient. "Mr. Miller, can you tell me what happened? What is this on your hand?" Through chattering teeth, he looked at me, his eyes struggling to focus. It came from the sky," he mumbled. "In the rain. This morning, in the field, it just fell. And that was it." My brain immediately categorized the statement, filed it away. Febrile delirium. Patients with high fevers are often confused. They say strange things. They have hallucinations. His story was not data. It was a symptom. The real story was in his blood and on his skin. I turned to the team. "Okay, let's treat this as a hazardous chemical exposure until proven otherwise. I want a full tox screen, blood cultures, a CBC with differential and a chemical panel, and let's get that stuff off his hand, carefully. I want to see what we're dealing with underneath." I was confident. I was in control. In my mind, the clock was already ticking, and in 60 to 90 minutes, the lab would send back a result that would give this chaos a name. "Let's be careful with this," I said to my lead nurse, Olivia Reed. "We don't know what it is, so we treat it as if it's everything." She was a good nurse, calm under pressure. She began the process of debriding the substance from Jacob's hand using sterile water and swabs. As she worked, I watched, my mind racing through a differential diagnosis. The substance itself was strange. It didn't have the viscosity of any commercial gel I knew. It wasn't sticky. It seemed to slough off his skin in whole, quivering pieces. It had no odor, which was unusual for a chemical agent. Underneath, his skin was a mess of angry, weeping blisters, but the pattern wasn't consistent with a classic thermal or chemical burn. It was wrong. This was the first moment of genuine intellectual dissonance for me. It wasn't just a puzzle. It was a puzzle where the pieces didn't seem to fit any box I had. "Doctor," Olivia said, her voice low, "it smells strange over here." I leaned in. "I don't smell anything," I replied, my focus on the blister patterns. "No," she said. "Not a chemical smell. It smells like ozone, like the air after a lightning strike." I probably gave her a dismissive look. In that moment, a subjective report about a smell was irrelevant noise. All that mattered was what we could see and what we could test. But the puzzle was getting more complicated. The visual data wasn't matching any known pathology. My confidence began to waver, just for a second, replaced by a flicker of frustration. But then I remembered the protocol. When the data you have is confusing, you get more data. And the source, the key to this whole thing, was sitting right there on his hand. "Olivia, wait," I said, my voice sharp. "Before you clean the rest of it off, get a sterile sample container. I want a large, uncontaminated sample of this gel. Get it to the lab, stat. Label it as a potential unknown toxin and put a rush on it." This was it. This was the anchor that would pull the case back into the world of logic. The sample was everything. I watched as Olivia carefully used a sterile tongue depressor to scoop a glob of the clear, quivering substance into a specimen cup. She sealed the lid, and it felt like we had just captured the solution. I was certain. In an hour, maybe two, the lab would call. They would have a name, a chemical formula, a logical explanation that would make this whole bizarre episode fall neatly, satisfyingly into place. My faith in the process was restored. While we waited for the lab, I did what I always do. I treated the man in front of me. We were pushing intravenous fluids to combat the dehydration from his fever, administering broad-spectrum antibiotics, just in case this was some bizarre bacterial infection, and trying to manage his escalating pain. All the while, he was getting worse. The The swelling, which had been confined to his hand and wrist, was now creeping up his forearm, the skin turning a deeper, angrier shade of red. His disorientation was worsening, his mumbled answers to our questions becoming more fragmented. Olivia would update me on his vitals every 15 minutes, and the trend was clear. His fever was climbing, his heart rate was accelerating, and his blood pressure was becoming unstable. Every instinct I had, honed by 15 years of experience, was screaming that this man was profoundly toxic, that his body was fighting a losing war against a powerful poison. I was just waiting for the lab to give my enemy a name. Then, the printer at the nurse's station whirred to life. The first results were back. I walked over and tore the sheet from the machine with a sense of confident expectation. This would be it. This would be the beginning of the answer. I scanned the columns of numbers, my eyes searching for the telltale flags, the values in bold that would point me toward the culprit. White blood cell count, perfectly normal. C-reactive protein, our primary marker for inflammation and infection, normal. Liver and kidney function, normal. I flipped the page to the comprehensive toxicology panel, a test that screens for over 300 common and uncommon poisons, from arsenic to cyanide to industrial solvents. The results were a clean, uniform column of text. Negative, 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 negative. I read it again, and a third time. It was impossible. It was a complete contradiction. The piece of paper in my hand, the pure objective data from the most advanced machines in the hospital, was telling me that Jacob Miller was, for all intents and purposes, medically fine. But 10 feet away from me, that same man was moaning in agony, his arms swelling like a grotesque balloon, his body succumbing to a violent systemic assault. This was the first true moment of vertigo in my career. For the first time, the data wasn't just confusing, the data was lying. My first reaction was not to question the data's authority, but to find a way to make it fit. It's what we're trained to do. When reality and the data don't align, you assume there's a nuance you're missing. The toxin must be a novel compound, I told myself, something our current tests aren't calibrated to detect. It must be a purely localized reaction, so potent at the point of contact that it hadn't yet entered the bloodstream in sufficient quantities to show up on a systemic panel. I was building a new box, a new set of logical parameters to contain the chaos. I was rationalizing. It was a frantic, desperate act of intellectual self-preservation. My faith in the blood work was shaken, but it wasn't broken. Because I still had a trump card. I still had the sample. My entire focus, all my professional hope, now pivoted to that small, sealed specimen cup making its way through the labyrinth of the hospital's basement laboratory. The blood work could be wrong, yes, but the physical evidence couldn't be. The lab had a gas chromatograph mass spectrometer, a machine that could take any substance and break it down to its fundamental molecular signature. It didn't need to know what it was looking for. It could simply identify what it was made of. That sample was my Rosetta Stone. It would translate this medical gibberish into the clean, precise language of chemistry. A sense of calm settled over me. We had a setback, but the protocol was still working. The process was still intact. We had the physical evidence, and that evidence would give us the truth. I remember walking to the staff lounge to get a cup of coffee, feeling the control of the situation returning to my hands. I even called the lab to check on the status. A young technician answered. "Yeah, doctor, we have your sample from the ER," he said, a hint of confusion in his voice. "We're having a little trouble with it on the slide. It's behaving strangely." I dismissed his hesitation as inexperience. "It's an unknown substance," I said, my voice sharp with authority. "That's why I sent it to you. Just get me the analysis stat." I hung up the phone, completely certain that my next call from him would be the one that solved everything. An hour later, the phone at the nurse's station rang. It was the lab. I picked it up, a pen in my hand, ready to write down a chemical name. "Holloway," I answered. It was the same technician, but the confusion in his voice had been replaced by a nervous, defensive tone. "Doctor," he started, his voice strained, "about that sample you sent down, the jelly." I waited. "We have a problem. There is no sample." My first reaction was a surge of pure, hot anger. This was a critical case. A man's life was on the line, and this was the time for some lab tech to make a clumsy mistake. "What do you mean, there is no sample?" I snapped. "Did you drop it? Did you contaminate the specimen?" There was a pause on the other end. "No, sir," he said, his voice dropping. "That's the problem. We did exactly what you asked. We prepared a slide. We put it under the microscope. We could see it clearly. It was cellular almost, but it was quivering, for lack of a better word. My supervisor wanted a better look, so he increased the magnification, which meant turning up the lamp's brightness." He took a breath. "Doctor, under the heat and the direct light, it just melted. Not like gelatin melting into a puddle. It turned into a clear liquid, and then, over the course of about 90 seconds, it just disappeared. It evaporated. Completely. There's nothing left on the slide. No residue, no moisture, no biological trace. Nothing. It's just gone." The words didn't compute. They were a string of sounds that my brain refused to assemble into a coherent reality. Evaporated, without a trace. That isn't how chemistry works. That isn't how matter behaves. It violates the fundamental laws of conservation of mass. It was, in a word, impossible. And then the technician, trying to cover his own department from liability, delivered the final, devastating blow. Are you sure of what you sent us, Doctor? I mean, are you sure it wasn't just water ice or something? The implication was clear. The problem wasn't the impossible substance. The problem was me. I hung up the phone. I didn't slam it down. I just gently placed the receiver back in its cradle, my hand feeling strangely heavy and disconnected from my arm. The chaotic symphony of the ER around me, the beeps, the voices, the rolling wheels, all of it seemed to fade into a distant, muffled roar. It was like I was underwater. I looked through the glass of the trauma bay door at Jacob Miller, his wife now at his bedside, holding his good hand, her face a mask of fear. And I did a mental inventory, a checklist of the tools I had left to fight whatever was killing him. A patient story that sounded like a delusional fantasy, blood work that screamed he was healthy, a lead nurse who thought she smelled ozone, and a phone call from a lab technician who thought I was an idiot. I had nothing. It wasn't that I had no answers. It was that I no longer even had a verifiable question. My one and only piece of concrete, physical evidence, the very thing my entire protocol depended on, had not just been lost. It had actively removed itself from existence. It was a perfect crime. The perpetrator had shown up, assaulted the victim, and then incinerated itself, leaving no fingerprints, no DNA, nothing but a victim whose injuries no one could explain. And in that moment, I realized the case had transformed. This was no longer a difficult diagnosis. A difficult diagnosis is a puzzle with a cleverly hidden solution. This was not a puzzle. This was a ghost story. It had ceased to be a medical problem and had become a piece of folklore, an anecdote. I could no longer prove that the substance on his hand had ever even existed, let alone what it was. I looked around the ER, at my colleagues, at the other nurses. How could I possibly explain this to them? How could I justify my next steps? I'm initiating an aggressive treatment for exposure to a substance that may have fallen from the sky and which subsequently evaporated in a sealed container in our lab. They wouldn't just laugh me off the floor, they would have me sent for a psychiatric evaluation. I was completely, utterly, and professionally alone. I was no longer treating a patient. I was treating a ghost. My medical degree was a useless piece of paper. With the lab results useless and the physical evidence gone, I was no longer practicing medicine. I was performing battlefield triage in the dark. The protocol, my trusted map, was now a useless, blank piece of paper. All I could do was treat the symptoms, the fire, without having any idea what was causing the blaze. It's a physician's worst nightmare, a complete reversion to the dark ages of medicine. We were essentially throwing the entire pharmacy at Jacob Miller, a desperate shotgun approach that I despised. We administered the most powerful, broad-spectrum antibiotics we had, in case it was a flesh-eating bacteria that our cultures somehow missed. We started him on an aggressive antiviral cocktail, on the infinitesimally small chance it was some novel hemorrhagic virus. I put him on a high-dose IV steroids, a blunt instrument designed to suppress his body's overwhelming inflammatory response, to stop his own immune system from killing him. It was medical guesswork, pure and simple. I was just trying to keep him alive, to manage his decline, while his body was being ravaged by an enemy I couldn't name. His wife would stand by the bedside, her eyes red from crying, and ask me the same question over and over. "What's wrong with him, doctor? What is it?" And for the first time in my career, the only honest answer was, "I don't know, but you can't say that." So I would give her vague, reassuring lies about a severe atypical reaction and how we were aggressively treating the symptoms. Every word felt like a betrayal of my oath, of my entire professional identity. I had to update his chart, and that was its own form of torture. I couldn't write the truth. I couldn't write. Patient was exposed to a gelatinous substance of possible extraterrestrial origin, which subsequently evaporated from a sealed lab container. They would have stripped me of my medical license, so I wrote a fiction. I used vague clinical language to construct a plausible, if incomplete, narrative. Patient presence with severe, localized edema and necrotizing cellulitis, etiology unknown, does not appear to be responsive to standard treatment. I was actively creating a false medical record because the truth was medically, professionally, and logically indefensible. I wasn't a scientist anymore. I was a storyteller, and I hated every second of it. In a situation like this, the protocol has a final failsafe: consultation. When you're faced with a complete mystery, you call for help. You bring in the experts. It was a humbling but necessary step. I arranged a case conference with Dr. Marcus Thorne, the head of our hospital's infectious disease department, and I got on the phone with a senior toxicologist from a larger medical center in Philadelphia. I laid it all out for them in one of the small, sterile conference rooms. I showed them the pristine lab results, the perfectly normal toxicology screens. I showed them the high-resolution photos we had taken of Jacob's hand upon admission, the strange, clear jelly clinging to the swollen, blistered skin. And then I had to tell them the story. I tried to keep my voice as clinical and detached as possible. I described the substance. I described the patient's account of it falling from the sky. And finally, I had to tell them about the phone call from the lab. I had to say the words out loud. The sample evaporated without a trace. The moment I said it, the atmosphere in the room changed. It wasn't a dramatic shift, but a subtle, chilling one. The look on Dr. Thorne's face went from professional curiosity to a kind of polite, condescending pity. The voice of the toxicologist on the speakerphone, which had been sharp and inquisitive, became slow and overly patient, the tone you use with a confused child or a hysterical parent. They started offering explanations, not for the substance, but for my observation of it. "Ben, are you sure it wasn't a common industrial polymer?" the toxicologist asked. "Sometimes farmers get exposed to strange fertilizers." He could be lying about the source to cover up his own mistake. Dr. Thorne suggested it was a highly atypical presentation of necrotizing fasciitis, the flesh-eating bacteria. Even though he knew the cultures were negative, he said, "Sometimes the initial tests can be wrong." They were doing what I had done at first. They were trying to force my impossible square peg of a story into the round holes of their own experience. But when I held firm, when I insisted on what I saw and what the lab had told me, their explanations became about me. The implication, never spoken but hanging heavy in the air, was that I had made a mistake, that I had mishandled the sample, that I was cracking under the pressure of a difficult case and was exaggerating, seeing things that weren't there. I left that meeting more alone than I had ever been in my professional life. They didn't see a medical mystery. They saw a colleague who was losing his grip. That night, I hit a wall. My shotgun approach to treatment was failing. Jacob was being moved to the ICU. My colleagues thought I was unstable. I was out of scientific avenues. Every logical path had led to a dead end. I went back to my office, the silence of the nearly empty hospital floor pressing in on me. I opened Jacob Miller's chart again, the pages now filled with my own useless notes and the dismissive consultations from the other specialists. I had read his lab results 100 times, as if staring at the word negative long enough would magically change it. But this time, I turned to the one page I had dismissed as complete garbage from the very beginning, the initial admission notes, the ones taken by the triage nurse. I ran my finger down the page, past the vitals, past the initial assessment, to the section marked Patient's Account, and I read the words again. But this time, I forced myself to read them differently, not as the ramblings of a delirious man, but as a factual statement. Patient states a jelly-like object fell from the sky during what he believed to be a meteor shower this morning. He found it in his field. He touched it. I felt like a fool. I felt like I was betraying my entire education, my entire belief system. This wasn't medicine. This was the script for a bad science fiction movie. My mind, the rational scientific part of me, was screaming, "This is insane. People do not get poisoned by things that fall from the sky. This is a dead end born of desperation." But a quieter, more desperate voice answered back. "Every rational dead end is already behind you. The data has lied to you. Your colleagues think you're a fool. This insane story is the only road you haven't taken." On a desperate impulse, I went to the small hospital library, a place I hadn't set foot in for years. I went to the computer terminal and, feeling like a complete idiot, I started searching. Unusual atmospheric deposits, gelatinous meteorites, toxic rain. Of course, I found nothing. Nothing in any respectable scientific or medical journal. The act itself was a symbol of my complete and utter desperation. I walked back to my office with nothing but the patient's story. I didn't believe it, not in any rational sense, but I had to accept a terrifying new possibility. In the absence of any other truth, the impossible might be the only thing I had left. Having made the decision to walk down that insane path, I realized I needed more. If I was going to entertain the patient's story, I needed more of the story. I needed the details I had previously dismissed as irrelevant noise. I needed the unscientific details. There was only one other person who had been there at the beginning, who had physically handled the substance. I found Nurse Olivia Reed in the staff lounge, looking exhausted. The usual confidence and energy she had on the floor were gone. She just looked tired and scared. My demeanor with her was different this time. I wasn't the confident, commanding attending physician. I was a man adrift, looking for any piece of driftwood to cling to. "Olivia," I started, keeping my voice low, "about the Miller sample. I need you to tell me everything, not what you wrote in the chart. I need to know what you saw, what you felt, no matter how strange it sounds. Please." She looked hesitant. She had seen the looks the other specialists were giving me. She was afraid of being associated with my crazy case, afraid I would think she was as delirious as the patient. "Doctor, she started, but I held up a hand. "There are no bad answers here, Olivia. There are no right answers. I just need to know what you experienced." She took a deep breath, and then she told me. She described the unnatural cold of the substance, a chill that seemed to suck the warmth out of the air around it, a cold she felt, even through her latex gloves. She described a faint, low-frequency vibration she felt when she got the swab close to it, like a humming, but a feeling, not a sound. And then she told me the part she had been most afraid to mention. She said that for a split second, under the bright, direct light of the examination lamp, she swore she saw something inside the jelly. Not just a random shape, but what looked like tiny, tiny filaments of light, moving like a spider web, or like a tiny living nervous system. Every word she said was a new kind of torment for me. As a scientist, it was anecdotal, subjective garbage. As a doctor with no other options, it was the only new data I had received in 24 hours. It was a meal of sand, but I was starving. I thanked her and walked away, my own mind reeling. I now had a collection of impossible facts, a story about a jelly that fell from the sky, a nurse's testimony about a cold, vibrating, light-filled substance that smelled like ozone. It wasn't a medical chart. It was the ravings of a madhouse. But it was the only case file I had left. The professional fallout began quietly, not with a confrontation, but with a polite, almost friendly summons to the office of the chief of medicine, Dr. Evans. He was a man I respected, an administrator who had once been a fine surgeon. He closed the door to his office, the sound a soft, ominous click. He had Jacob Miller's chart open on his large mahogany desk. He wasn't looking at me. He was looking at the chart with a deep, troubled frown. "Ben," he began, his voice calm and even, "I'm looking at the chart for the farmer you have in the ICU, Mr. Miller. I've been reviewing the billing flags from the pharmacy. You have him on high-dose meropenem, foscarnet, and systemic corticosteroids. The resource expenditure on this patient is significant." He looked up at me, his eyes searching mine. "And I've been reviewing his lab work, all of it. Ben, there isn't a single positive result in this entire chart. His blood is clean. His tox screen is clean. His cultures show no growth. So I need you to tell me, what exactly are we treating?" The question hung in the air, cold and sharp. I couldn't tell him the truth. I couldn't say, "We are treating a man who was exposed to a gelatinous substance that fell from the sky and then evaporated from our lab." So I did what any doctor in an impossible situation would do. I danced. I used the jargon. "Well, we're treating a severe, aggressive, and currently unidentified systemic inflammatory response, possibly secondary to a novel necrotizing cellulitis." He wasn't buying it. He leaned forward, his voice losing its friendly edge. "Your consultants from toxicology and infectious disease don't seem to agree with that assessment," he said flatly. "Their notes suggest that the physical evidence is anecdotal. Ben, from a risk management standpoint, this chart is a time bomb. You are administering a battery of aggressive, high-cost treatments to a patient who, on paper, has nothing demonstrably wrong with him. If this man expires and his family decides to sue, this chart will not protect you. It will not protect this hospital. It will bury us." The threat was unspoken, but it was crystal clear. My clinical judgment, my professional reputation, my very career were now under a microscope. He was telling me, in no uncertain terms, to stop treating the man in the bed and start treating the chart on his desk. I walked out of that meeting and went straight to the ICU. The administrator's warning was still ringing in my ears, a cold counterpoint to the frantic, high-pitched beeping of the monitors around Jacob Miller's bed. The battle was being lost. The shotgun treatments were having no effect. The necrosis, the tissue death, was no longer confined to his hand and forearm. A dark, purplish line, the demarcation of the advancing front, was now creeping past his elbow. The skin was beginning to slough off in wet, weeping sheets, and the clear, odorless fluid that oozed from the blisters had started to dissolve the sterile dressings we applied. His vitals were a chaotic, terrifying symphony of failure. His blood pressure was plummeting, forcing us to start him on vasopressors, powerful drugs to artificially constrict his blood vessels just to keep blood flowing to his vital organs. His fever was now over 105 degrees, a temperature that was essentially cooking his brain. He was on a ventilator, a machine breathing for him, its rhythmic whoosh and click the only sign of respiration. And in the middle of this horrifying, undeniable physical collapse, a nurse handed me the latest round of lab results fresh from the printer. I had to sign off on them. I stood there at the foot of the bed of a man who was actively dying, and I looked at the paper in my hand. Kidney function, normal. Liver enzymes, normal. White blood cell count, normal. It was the most profound and complete failure of science I had ever witnessed. It was a medical nightmare. I was a captain on the bridge of a sinking ship, and all of my advanced navigational equipment was screaming that the seas were calm and we were perfectly safe. Jacob's wife was standing in the corner, her face a pale, tear-streaked mask of grief. She looked at me, her eyes pleading. "He's not getting better, is he, doctor?" she whispered. And I had to look that woman in the eye, a woman whose husband was being erased from existence in front of us, and I had to lie. "We're doing everything we can," I said. The words tasted like ash in my mouth. I was no longer a healer. I was just a helpless witness to an impossible death, armed with a mountain of official, documented proof that it wasn't happening at all. Jacob was circling the drain. We all knew it. The ventilator was breathing for him. The pressors were forcing his heart to beat, but he was gone. He had hours, maybe less. My career was already over. I could feel it. The moment he flatlined, Dr. Evans would convene a review board. My chart would be torn to shreds, and I'd be lucky to keep my license. I was at the absolute bottom of a professional, intellectual, and ethical hole. I went to the small, empty doctor's lounge, the fluorescent lights humming overhead, and I put my head in my hands. I was out of scientific options. The protocol was finished. All that was left was the noise, the nonsense, the anecdotal garbage I had so arrogantly dismissed. And in that moment of complete desperation, I forced myself to listen to it. I made a list in my head. Fact 1, the patient says it fell from the sky during a meteor shower. Okay, so atmospheric, non-terrestrial. What does that mean? Strange elements, radiation? Fact 2, Olivia smelled ozone, the scent of a lightning strike. So, some kind of electrical charge or high-energy property. Fact 3, Olivia felt a vibration, a coldness, and saw light moving inside it. So, not a simple chemical. Something with its own energy source? Something biological, but in a way I couldn't comprehend? It was madness. It was a collection of ghost stories, but I synthesized it into a single, desperate, insane theory. What if this wasn't a chemical poison in the traditional sense? What if it was a kind of energy-based organism, a biological battery, and its poison was a form of radiation or an electrical field that was short-circuiting his cells? It was a lunatic idea, a hypothesis born of pure science fiction. But it led to a question: how do you treat that? You counter it. You introduce something that could absorb or neutralize that energy, and a single, obscure treatment came to mind. A massive, off-label, and incredibly risky dose of a specific chelating agent, Prussian blue, typically used only for catastrophic radiation poisoning or thallium exposure. It was a shot in the dark, a complete violation of every protocol. I knew if I was wrong, the dose itself could kill him. I walked out of that lounge, went to the ICU pharmacist, and I bullied her into giving me the dosage. I didn't have a diagnosis to justify it. I had a ghost story. And I was betting my patient's life and the last shred of my career on it. The next 12 hours were the longest of my life. I administered the Prussian blue myself, a deep, impossibly dark liquid flowing into the IV line of a man who was, for all intents and purposes, already gone. And then we waited. For 2 hours, nothing. His vitals remained critical. And then, slowly, miraculously, impossibly, something changed. His blood pressure began to stabilize, just a few points at first, but it was the first upward trend in over a day. Then his fever began to drop, 1/10 of a degree at a time. By morning, the angry red line of the necrosis on his arm had not advanced another millimeter. It had stopped. My insane, unscientific shot in the dark had worked. In the weeks that followed, Jacob Miller made a slow, painful, but steady recovery. We saved his life, and we saved his arm. But my own nightmare was just beginning. I had a miraculous recovery on my hands, one that had resulted from a treatment based on a theory I could never, ever admit to. I had to create a story. I had to build a clean, logical, and medically defensible narrative for his chart. And so I sat down to write the discharge summary, the official final word on the case. It was the most creative piece of writing I have ever done. I described his initial presentation, the severe edema and blistering, and I created a plausible fiction to explain his recovery. I wrote that, after failing to respond to conventional treatments, the patient had a spontaneous and dramatic positive response to broad-spectrum chelation therapy, suggesting exposure to an as-yet unidentified heavy metal toxin. It was perfect. It sounded smart. It was technically true. I had used a chelating agent. And it was completely unprovable, and therefore completely unchallengeable. I methodically and deliberately omitted every single piece of the real story. There was no mention of the translucent jelly, of its pulsing nature, of the patient's story about the sky, of the nurse's sensory report, or most importantly, of the sample that had vanished from the face of the earth. I erased the impossible. I told myself I was doing it for the right reasons. I was protecting the hospital from a lawsuit, protecting myself from a malpractice claim, protecting the patient from being labeled a lunatic for the rest of his life. But I knew, deep down, that it was an act of profound intellectual cowardice. I had just witnessed what could have been the most significant medical event in human history, and I was burying it under a pile of jargon. I signed my name at the bottom of the chart, and with that stroke of a pen, the official history was written, and the truth was buried forever. In the end, I had 2 records of the Jacob Miller case. The first was the official one, the one that lives in the hospital's archives. It is a neat, tidy, and thoroughly dishonest document. It's a work of fiction, crafted with the specific purpose of closing a loop, satisfying an administration, and protecting a career. And then there was the second record. The night before Jacob was discharged, I stayed late in my office long after the last shift change. Under the quiet hum of a single desk lamp, I didn't just photocopy my notes. I wrote a complete, detailed, and entirely truthful account of the entire event. I wrote down Jacob's delirious story about the meteor shower, word for word. I documented Olivia's initial hesitant report of the ozone smell, the cold, and the impossible vibration. I detailed my phone call with the terrified lab technician, including his final dismissive question of whether I had sent him a sample of ice. I described my insane, desperate leap of logic that led to the Prussian blue treatment. I printed the high-resolution photos we had taken of the gelatinous substance on his hand. I compiled everything: the lies of the official lab reports, the truth of the unscientific anecdotes, the photographic evidence of a thing that no longer existed. It was a dossier of madness. It was the case file of an impossible event. I didn't do it with any intention of ever showing it to anyone. It was a purely selfish act. It was an act of rebellion against the clean, sterile lie I had been forced to codify into the official record. It was my way of preserving my own sanity, a desperate need to create a physical object that would prove to myself in the lonely years to come that I had not imagined it all. That night, I took the thick manila folder home. I didn't put it in my study with my medical journals. I took it down to my basement, and I placed it inside an old locked footlocker that contained my father's effects from the war. It felt like the right place for it. This file was no longer a medical document. It was the record of a battle, a secret history of the one time the rules of my world were completely broken, and I was the only one who had taken notes. Years passed. I didn't lose my job. I was never formally reprimanded. The Jacob Miller case, in the official memory of the hospital, became a minor legend, a case of a brilliant but unorthodox diagnosis for a rare heavy metal poisoning. I became the doctor who had saved a man with a wild, intuitive leap. They celebrated the lie. I continued to be a good ER doctor. I was efficient. I was effective. I saved lives. But the man I was before that case, the supremely confident conductor of the ER orchestra, was gone forever. The certainty had been surgically removed from me, and in its place, a permanent low-grade hum of doubt had been implanted. I could feel the change in my own practice. Before, a patient with baffling symptoms and clean lab results was an interesting puzzle. Now, they were a source of a specific, cold dread. I would find myself lingering at their bedside, asking different questions. Questions the old me would have dismissed as irrelevant noise. Have you been anywhere unusual? Eaten anything strange? Noticed anything out of the ordinary, no matter how small? I started listening to the stories again. I couldn't help it. My colleagues noticed the shift. I gained a reputation for being eccentric, for ordering second and third rounds of tests on cases that seemed closed, for being unwilling to discharge a patient just because their chart said they were fine, if my own eyes told me something was still wrong. They thought I was just being overly cautious, maybe a little paranoid in my old age. They didn't understand. They couldn't understand. Every time I held a lab report in my hand that read negative, my mind would flash back to Jacob Miller's chart. The memory of that case had become a permanent silent asterisk attached to every piece of data I ever read. It was a ghost in my machine, a constant, unsettling reminder that the map is not the territory, that the data can lie, and that the beautiful, orderly system of science I had built my life upon had a hole in it, a hole big enough for an impossible truth to fall right through. About 10 years after the Miller case, I was at a medical conference in Philadelphia. During a break, I ran into a surgeon who had been a resident at my hospital back in 2009. We were catching up, making the usual small talk about careers and families. And then he asked me, "Hey, whatever happened to that sharp ER nurse who used to work with you? The quiet one, Olivia Reed? She just disappeared." I told him I wasn't sure, that I heard she had left medicine shortly after that year. And then he said the words that stopped my heart. "That's a shame," he said, shaking his head. "I ran into her sister at a party a few years ago. She said Olivia had developed this bizarre, chronic skin condition on her hand. Some kind of weird rash and a strange pattern that no dermatologist could ever identify. Real shame." He said it so casually, a piece of idle gossip, a random bit of trivia. But for me, it was like a lightning strike. It was a delayed echo from the original explosion, a piece of data I never knew existed. I felt the floor drop out from under me. I excused myself, my mind reeling. I went straight back to my hotel room. The first thing I did when I got home from that conference was go down to the basement and unlock the old footlocker. I pulled out the secret file. My hands were trembling as I opened it to the high-resolution photos we had taken of Jacob's hand. I stared at the bizarre, weeping blisters, at the strange, almost geometric pattern they had formed on his skin as the necrosis began. A pattern that, if you looked at it long enough, almost resembled a constellation. And I knew, with a certainty that made me feel sick to my stomach, that if I could see Olivia Reed's hand right now, I would see a fainter, smaller but identical pattern. It was another piece of the puzzle, another piece of subjective, anecdotal, unprovable proof. It was a horrifying secret validation of what I already knew, The thing from that field hadn't just poisoned Jacob Miller. A part of it had clung to the nurse who had been brave enough to get close. It didn't bring me any peace. It just added another layer of weight to the impossible secret I was forced to carry. I used to believe that the worst thing in medicine was ignorance, to be faced with a dying patient and have no idea what was wrong or how to help. I spent the first half of my career terrified of not knowing. The Jacob Miller case taught me that my fear was naive. There is something far worse than ignorance. There is knowledge. The true hell is knowing, with absolute certainty, what happened, but having that knowledge be something so impossible, so completely outside the guardrails of accepted reality, that you can never speak it out loud. It's a unique and exquisite form of torment. I am a prisoner of an extraordinary truth. If I had followed the protocol, if I had listened to my consultants, Jacob Miller would have died, and I would have been a failed doctor, my career tarnished by a single inexplicable death. But because I took a lunatic leap of faith based on a ghost story, he lived. And I became a successful doctor who must spend the rest of his life guarding a lie. I am trapped, not by my failure, but by my impossible success. That secret file in my basement is more than just a collection of papers. It is the physical manifestation of that burden. It's a truth that can never be published, a discovery that will never be celebrated. It's the final, complete record of the day I stopped being just a doctor, and became the sole guardian of a secret I wished to God I had never learned. My career didn't end in 2009, but my certainty did. I still walk the floor of the ER. I still follow the protocol. I still trust the data. But I do it all with a silent asterisk in the back of my mind, a permanent footnote that reminds me of the one time the data lied, the protocol failed, and the only thing that worked was a desperate, terrifying shot in the dark. In the end, it all comes down to a single impossible choice. As a doctor, I took an oath to do no harm and to trust the evidence. But what do you do when the evidence itself violates the laws of physics and then vanishes? What do you do when your choice is between the protocol that is failing and a story that sounds like madness? It leaves me with one question that has haunted me for over a decade. Who do you trust? The lab report that says nothing is wrong, or your own eyes that have seen the impossible? If this medical mystery challenged your understanding of the world, please leave a like and share this video with someone who appreciates a true, unexplained case. What would you have done in my position? Let us know your theory in the comments below. I also have two important questions for you. From what city are you watching? And right now, look at your clock and type what time it is in the comments. For more doctors' reports that examine the data from cases that defy all explanation, subscribe to Medical Records Unexplained. And don't forget to check out our playlist of other documented cases that left doctors baffled and questioning everything they thought they knew.